The title of my talk is Precision Medicine Bearing Fruit. And indeed, it has in this disease, and I hope to convince you of that. I usually use this slide for fellows to show that biliary cancer is not one entity. You can see hilar cholangio at the upper left, where you barely see the mass, but you see dilated bile ducts, gallbladder cancer on the upper right, with invasion in the subjacent liver. And then at the bottom, you have intrahepatic cholangiocarcinoma, mass in segment 4, with no biliary ductal dilation. And this is the most rapidly rising cancer one of the most rapidly rising cancers in the Western world. These cancers have different epidemiological trends. The clinical presentation differs, different pattern of genetic alterations. So they are indeed disparate. These cancers are considered rare. And by rare, I mean less than 6 per 100,000. About 2 per 100,000 in the Western world, not so rare in China, Thailand, Korea, Japan, especially in northern Thailand, where it's 85 per 100,000. In India, according to the ICMR statistics, it's somewhere close to the Western world, about 2 per 100,000. A completely different pattern of distribution for gallbladder cancer, a disease which you know well in India, a great burden of this disease. Also in Latin America, particularly in the West Coast, Western United States, Eastern Europe, East Asia, a different distribution. And what is interesting and alarming is that intrahepatic cholangio, which is the curved line in blue, is rapidly increasing in the Western world, whereas extrahepatic cholangiocarcinoma, Klatskin, perihilar are relatively stable. The reasons for that are not quite known. We think that because we used to call it cancer unknown primary in the liver, now it's different. We call it intrahepatic cholangio. It could be artifactual, but it should be balanced by the fact that Klatskin tumor or perihilar that was formerly called intrahepatic is now called extrahepatic. We believe this is a true increase, which is a lifestyle issue. Parallel rise of obesity, alcohol, substance abuse, leading to steatohepatitis and cancer. In diagnosis of intrahepatic cholangiocarcinoma is a diagnosis of exclusion. So I often see patients in practice who have really millions of dollars of workup, whereas really the key is in histology, adenocarcinoma, CK7 positive, CK20 positive and negative, and exclusion of others like TTF1, HepPAR1. In situ hybridization for albumin is relatively specific, but not commonly available. This characteristic pattern of IHC is probably enough to make the diagnosis. This is going to be the focus of my talk in terms of novel therapeutics. We'll talk about molecularly targeted agents, novel cytotoxic, and immunotherapies. Even today, unfortunately, our standards are based on a trial conducted a decade ago with gemcitabine versus gemcitabine and cisplatin from UK, the Advanced Biliary Cancer Group, which showed a survival of 11.7 months with gemcitabine and cisplatin versus 8 months with gem alone. Unfortunately, even today, a decade later, this is a standard of care, and you have a survival of average of 1 year with patients to the clinic. In our group at MD Anderson and Mayo, we did a study adding nab-paclitaxel or Abraxane to gemcitabine and cisplatin. This was a single-arm phase 2 study of 60 patients. In this single-arm study, this is the single quite promising, with a median progression-free survival of 11 months and overall survival of 19 months, a response rate of 45%, and interestingly, 20% of patients who were inoperable became operable. So now we're investigating as a neoadjuvant study. So this promising signal has led to a phase 3 trial of the triplet versus the doublet, led by my colleague, Dr. Shroff. This study has completed accrual, and we'll see the signal next year. In Asia, the S1 has added to gemcitabine and cisplatin in the Mitsuba trial in Japan. And as you can see this curve in the light pink, there was a marginal improvement in survival, but this is currently the standard of care with S1 and gemcis in China, Japan, and Korea. An ongoing study is with this interesting metabolite, the NUC 1031, which releases a higher amount of gemcitabine triphosphate in the tissue. So the question that this drug poses is, if you deliver more gemcitabine to the cell, does the tumor become more responsive? So this is being investigated in a phase 3 trial by my friend Jennifer Knox of gemcis versus this NUC 1031, also called as Accelerin, in combination with cisplatin. The study has kind of almost completed accrual. So really, cytotoxic are an area of great development in this disease. In terms of second-line therapy, the options are generally limited. FOLFOX is a regimen developed at ABC group in UK, PFS of 4 months, OS of 6 months. So while this is standard, it's not a wonderful standard. More recently, there's been a study of nanoliposomal irinotecan, quite similar to the pancreas cancer study that was presented here, compared with 5-FU leucovorin. And as you can see, the curve in blue, there was a splitting of the survival curves with progression-free survival. So perhaps this is now an alternative regimen. So my fellow Madhu Yaluri at the ASCO this month actually, she looked at patterns of care in 1,000 patients with cholangiocarcinoma and biliary tract cancer. The blue reflects the first line, gemcitabine. So 85% of patients get gemcis. Only 45% of the patients get second-line therapy, mostly the green, which is the 5-FU-based therapy, and only 17% get third-line therapy. So the median duration of therapy, first line is 3 months, and second line is 2 or 3 months. The smaller line, pink and orange, reflect targeted therapy. So clearly, biliary tract cancer is an area of great unmet need and quite different from many other hematological malignancy. This field has been greatly incentivized by next generation sequencing and the advent, and these two seminal studies, one from Hopkins and the other from NCI Singapore, which showed that that biliary tract cancer, particularly cholangiocarcinoma, is enriched with a large number of actionable mutations. This was our own work for about 400 patients, and you see 3 curves here: intrahepatic ICCA, extrahepatic ECCA, and gallbladder cancer. In bold are the actionable mutations. So you have IDH1, FGFR, BRAF in ICCA, KRAS, P53, not actionable in ECCA, but you have HER2. And gallbladder cancer is really percentage of patients like breast cancer, 15% HER2 amplification. So this has incentivized research in this field and accelerated drug development. These are results of our work looking at the next generation sequencing profiles with our colleagues in Shanghai and in the ones at MD Anderson. On the left is China, on the right is the US. So similar pattern of genes, but different distribution. So you have KRAS, P53 higher in China, more actionable mutations, whereas less mutations, but more actionable mutations in the West with IDH1 and FGFR. These types of molecular differences need to be accounted for. TMB is higher in the Asian population. What was not reflected there was DNA damage repair genes. This is some of our work presented by a fellow in Nature scientific reports showing the high percentage of DNA repair genetic alterations in gallbladder cancer, raising options for PARP inhibitors and other DNA repair inhibitors. I'm going to go to the first part of this first targeted therapy developed here, which was IDH, isocitrate dehydrogenase. We'll remember from Krebs cycle in medical school. In the presence of mutation, you get less alpha-ketoglucarate and more mutagenic 2-hydroxyglucarate, which results in altered epigenetic regulation and altered differentiation and oncogenesis. So this drug, ivosidenib, is already approved in acute myeloid leukemia with IDH1 mutation, was studied in the Clarity trial for patients who had received first-line gemcis. They were treated with ivosidenib versus placebo in a 187-patient trial with a crossover design. So we enrolled very rapidly on this trial, and the PFS being the primary endpoint. You see the blue line, which was the PFS with ivosidenib, splits clearly away from the placebo. The result was achieved, but very modest. The median PFS 2.7 months with Evo versus 1.4 months with the placebo. Survival 10.8 with Evo, with 9.7 with placebo. But you can't really tell that because this is sort of a crossover study design. But when you take away the noise that results from this crossover with using a statistical modeling method called rank-preserving structural failure time method, then the survival curves actually split, the green and the blue, 5 months versus 12 months, which led to this drug being FDA approved. The toxicity of this drug is actually quite modest. You see the toxicities here: nausea, diarrhea, fatigue, abdominal pain, not uncommon with biliary tract cancer. In fact, more people discontinue the placebo due to toxicities than ivosidenib. So incredibly well-tolerated drug, an option for patients with IDH1 mutation. Then the question arises, why do these patients get resistant? So there's some work by my colleague David Harding at Memorial Sloan Kettering. He did pre and post biopsies of the tumor and pre and post liquid biopsies. And he showed this figure, as you see this line in red, variant allele frequency of IDH1R132. As it goes down, actually you see increase in IDH2R172. So this is a resistant gene. And conversely, when you look at leukemia, we treat IDH2 mutation with inacitinib. You see as the IDH2 mutation goes down, IDH1 mutation goes up. So this is a form of isoform switching, mechanism of resistance, and possibly opening avenues for therapy. Next, I'm going to FGFR signaling, which has really been a focus of our work now for over 5 years. It's been investigated for decades. FGFR pathway is activated by mutations, amplifications, fusions, most commonly in fusions. So actually, Arul Chinayan from University of Michigan first described this in 2013, FGFR fusions. Fused to another gene, sort of like BCR-ABL, leads to oncogenesis through activation of downstream RAS, RAF, MEK, PI3, AKT pathways. A fellow of mine, Dr. Jain, she looked at FGFR alterations in about 100 patients and found that this disease occurs in earlier stage of the patients with FGFR alterations are at earlier stage of disease, more women, and they have a better clinical prognosis, a more indolent history. They have a distinct pattern of concurrent mutations like CDKN2A, TP53, KRAS, which have implications for innate resistance, which I will describe in a few minutes. So really, the first study we undertook was with this drug, infigratinib, which was a FGFR 1 to 3 directed tyrosine kinase inhibitor. Patients who had received GemCis and then had progressed were treated with single agent infigratinib till progression, with the primary endpoint of overall response rate and duration of response. And as you can see here, this was achieved. The response rate was 34% in patients who had received 1 line of therapy, 14% in patients who had received 2 or more lines of therapy. Best overall response was pretty high, 27 to 42%, investigator assessed, and the disease control rate was over 80%. We first saw this waterfall plot with infigratinib, not really what we are used to seeing in biliary tract cancer cholangio at all, where majority of patients showed type of response or improvement. And then since then, there's been pemigatinib, futibatinib, derazantinib. Pemigatinib was the first approved FGFR agent in cholangio, the first drug to be ever approved in this disease. And they have somewhat different degrees of response rates, disease control. Progression-free survival is really not that different, 7 to 8 months. So resistance does occur. They have a distinct pattern of toxicities, which include hyperphosphatemia, nail changes, eye changes, and asymptomatic retinal detachment in a small number of patients, and some non-specific like fatigue and arthralgia. These drugs, which I mentioned, don't act very well in FGFR mutations. They act more in fusions. So mutations occur in 3 to 4% of patients, and these are data that we presented just a few weeks ago at the ASCO meeting with derazantinib. So these are FGFR mutations in the kinase domain. Derazantinib is a multi-targeted tyrosine kinase inhibitor that seems to have some activity in FGFR mutations, opening an option for this disease. So I'm going to present this case to demonstrate innate resistance. This was a 76-year-old patient who came to my clinic, had progressed on GemCis, had an FGFR fusion. He was an ambassador from a country. I was very happy to see that I have something to treat him with. Unfortunately, the first scan, 2 months after infigratinib, shows progression in the primary tumor and multiple mets. So what happened here? We found that this patient had a concurrent CDKN2A loss, deletion of that gene. And in fact, when we looked at all patients treated with infigratinib and pemigatinib, we found that the most common concurrent mutation is BAP1, which has no prognostic significance. However, patients with CDKN2A, TP53, and KRAS, they have a poorer outcome. They don't really do that well with any of these FGFR therapies. So there is an opportunity here to perhaps combine with FGFR with other TKIs which may target these pathways. We know for a while in the lab that when you treat cells which are FGFR altered with FGFR inhibitors, they develop mutations, so activating mutations in the kinase domain. And they can also develop alternate activating pathways, such as EGFR and HER2, and downstream bypass signaling, such as PI3 kinase, AKT, KRAS, RAF, MEK pathway, etc. So these was very elegantly demonstrated in clinical studies. Now, my friend Litika Goel at MGH, she treated patients with infigratinib, obtained pre and post biopsies. The patient had FGFR fusion, and then on progression had a variety of mutations that you see here, polyclonal mechanisms of resistance that can be targeted by a covalent or irreversible inhibitor like furibatinib. And then also seen on the right is with pemigatinib, it shows the activity of pemigatinib in the and development of resistant mutations in the kinase and the extracellular domain, which can be perhaps targeted with other drugs. So now there are two drugs, FGFR inhibitors, that are developed for resistant FGFR mutations. First is the Relay 4008 drug, and this that you can see the darker green bars, which are patients who have received prior FGFR inhibitor, and a Chinese agent, a TT00420 that we are studying, also showing a very nice response to resistant FGFR. So it's sort of like non-small cell lung cancer, opening up various pathways. But I want to point out that genetics is not the only mechanism of resistance. So there's a patient, 49-year-old, who came to my clinic with this large mass encompassing the portal vein, of course not resectable, got GemCis, then got radiation because it was vascular, almost like HCC, got TACE, capecitabine, then FGFR altered, so therefore got derazantinib. 2.5 years of liver-limited disease, so clearly a better history. We did a liver transplant, and in fact, we published a recent series in a couple of journals here, which showed that about 60% of these patients with intrahepatic cholangio can have long-term survival as long as you select them properly and they have liver-limited, but yet unresectable disease. So the treatment of these patients is multidisciplinary, not just targeted TKIs alone. Moving on quickly, BRAF V600E, nice study by my colleague, Dr. Subia, in a basket study, 40% response rate, 8 months duration of survival. Our own work with HER2 amplified biliary tract cancer with trastuzumab and pertuzumab, 23% response rate, deep responses sustained as long as 8 months. And then a new drug being studied by my friend Dr. Shubham Pant, where is zaratumumab. It's a bispecific antibody with the trastuzumab and pertuzumab binding domain. 40% response rate in the phase 1 study, now being investigated in a multi-center international pivotal trial. Hopefully we'll get this drug, this approval. In the last couple of minutes, I'm going to move to immunotherapy, which is really the talk of the day now. Immunotherapy, as you know, correlates well with mutational burden, which is higher in melanoma, squamous cell cancer. The TMB in cholangio is low, but there are 7 patients with intermediate or high, and then 1% have MSI, high. So the keynote pembrolizumab study showed a response rate of about 5% in patients who were unselected for PD-L1 and 13% in those who were enriched for PD-L1. So there is a response, although it's a modest response. Similar data with nivolumab, 11% response rate. And as you can see, these orange bars on the right, there's a correlation between PD-L1 expression and outcome. So the question is, can we combine the T cell response to the tumor is inhibited by a variety of other checkpoints besides PD-L1? What about EP and Nivo? In a small Australian study at 23% response rate. But the elephant in the room was, of course, the Topaz-1 study, which was presented just over a week ago at ASCO GI. And I'm very proud that this study occurred in India. There were 4 or 5 sites in India. 650 patients randomized to GemCis and Durva versus GemCis and placebo. And then after 6 months, the chemotherapy was stopped and they got either maintenance Durva or maintenance placebo. Primary endpoint was overall survival. And although the median overall survival was modestly increased from 11.5 to 12.8 months, there was a tail in the curve, similar to what I saw a few minutes ago in esophageal cancer, where 2 years, 10% versus 24%. So this benefits patients who don't want to be on lifelong chemo. They can get maintenance Durva. It's not coincidental that these curves split at 6 months, which is the time when you stop chemo. So when you look at the forest plot, there is some interesting signal. That is the Asian population. I'm not sure you can see my cursor, but somewhere in the middle, Asian population splits away. They seem to benefit more than the non-Asian population. You have the intrahepatic cholangio, and extrahepatic seems to benefit more than gallbladder, but this is a small number of patients. No real relation between PD-L1 expression and outcome, where sort of the curves are all benefiting. So we don't really know the response to PD-L1. An improvement in PFS of 7.2 months versus 5.7 months, and improvement in overall response rate with 18 months to 26%. So the sum is greater than its parts. It was actually a positive trial. And if you look at the toxicity, I just highlighted a couple here to show that there's no difference between the Durva and the placebo arm, really quite similar. So really well tolerated therapy. And so I hope that Durva Gemcis now becomes a standard of care. So in the last couple of slides, how do you evaluate targeted therapy in an uncommon cancer? I've been working on this for 10 years. Nobody ever was interested. But now everybody is, because now we have targets. So we can have target-specific cholangio trial where the incidence is high, such as IDH and FGFR. When the incidence is low, then I rely on my phase 1 colleagues to do basket trials like BRAF, NTRK, MSI, HER2. But where we are going is an umbrella that can open in Mumbai and Bangalore, as well as it can open in anywhere in the world with multiple arms where patients can get access to these therapies. So how far have we come? There was no drug ever approved before 1990. Gemcis was just a sort of standard of care. We have 3 FDA approvals in 1 year, several NCCN designations. The advent of molecular profiling, targeted therapies, multi-agent chemo has led to a sea change. IDH, FGFR, HER2, BRAF. The next step is DDR, DNA damage repair. Immunotherapy is a promising area. Now we have the first positive phase 3 trial. Predictive markers remain elusive. Heterogeneity, Asian, non-Asian, like we do in HCC, needs to be considered. And clearly, I believe this is a model for precision medicine. So I would be remiss if it requires a village to treat an uncommon cancer. I have colleagues really all over. Some of them are mentioned here, the Hepatobiliary Task Force of NCI that I lead, SWOG, and funded by the Department of Defense. Besides Anderson, several of these foundations are very instrumental to our work and support us clearly. And, having trained in India, I always read T.S. Eliot. Only those who will risk going too far can possibly find out how far one can go. And there is a journey, and I'm happy to be a part of it. So I thank you again for inviting me to this meeting, and I look forward to attending more of your sessions in the future.
Thank you, Dr. Millind Javle. That was a fantastic talk. And you showed how the stalemate has finally been overcome in this particular malignancy. And the molecular profiling has really opened the floodgates. And now I would request Dr. Rangarajan to actually have a Q&A with you. He is going to be asking some questions on our behalf. So Dr. Rangarao, please.
Yeah, thank you, Dr. Millind. I think that is an excellent review of the cholangiocarcinoma. And that was, also we had a wonderful lecture on the pancreatic cancer also by the previous speaker. Very good. And we're going to have a very nice lecture by Dr. Amol, by some real work done on the gallbladder here. I just have one question. While we're all waiting for the new markers and the new targeted therapy, what is the data of the trastuzumab in the HER2 positive gallbladder cancers? I mean, I don't know whether
Sure. So trastuzumab is an effective agent. I mean, we did some of the original studies which showed 5 to 10% responses. Then we did a trial, Dr. Rangarao, with FOLFOX, and honestly, the activity is pretty good, 25 to 30%. But resistance develops quite often. And I think the future really for HER2 in this disease, I don't treat breast, perhaps it's like breast, is ADCs, like, Enhertu and those sort of drugs, or these bispecific molecules like Shubham is developing, with zanidatamab. So it's a small fraction of biliary tract cancer, but it clearly is a proof of concept that molecular profiling is of great value, especially for us in India, where HER2 immunohistochemistry is not that expensive, and it opens doors for treatments with gallbladder cancer.
Right. Thank you. And since they are fast-growing and also highly vascular tumors, some of them, is there any potential role for the anti-angiogenic agents? Yeah,
so, there have been trials with, there was a trial run by my friend, Dr. Vale with ramucirumab in first-line Gemcis versus Gemcis. It was a negative trial, unfortunately. We have a paper coming out in a journal very soon, Clinical Cancer Research, where we investigated single agent ramucirumab. And actually, it's sort of like gastric cancer, where you need prolonged stability in some patients. I think there's role, but it's so far being slightly incremental. It's not been, very dramatic.
Yeah. Thank you. I think wonderful deliberation. And let me see if there are any questions in the chat box. I think none. So over to you, Dr. Smriti. Thank you very much.
Thank you, Dr. Rangarao. Dr. Millind Javle, thank you so much.